The next speaker is Dr. Emma Burkitt Wright, who comes to us from the UK, and she will be speaking about the fact that genotypes matter. How can or should we incorporate allele-specific information into clinical management guidance? Emma.
Well, thank you for the kind invitation and kind introduction. What I haven't had is the briefing on how not to wreck the technology, which, as any of you who know me will know, I'm very good at. So, right-hand button. Oh, okay. Right, the right-hand button once. Yes, okay. No relevant financial disclosures. Relevant disclosure would be this talk has more questions than answers, and that no, the guidance isn't quite finished yet. That really is, I don't think that's all me, but there we go. Okay. There we go. That arrow seemed to work, or was it that on a delay?
Switch this real quick.
Okay.
Sorry.
Computer's getting tired. Thank you. So, am I allowed to just touch the computer, or will I break it, do you think? In this talk, I'll refer to Noonan syndrome spectrum disorders. That's a pragmatic term for the group of conditions that we've had within the scope of the management consensus guidance that we've been drawing up. And it's intended to describe Noonan syndrome in its classical form and the associated conditions, such as Noonan syndrome with multiple lentigines, Noonan syndrome with loose anagen hair, CBL syndrome, but also to recognise that Noonan syndrome and CFC syndrome do represent a continuum, and there are certain patients who sit right within the middle of that continuum, albeit quite rarely. So what's definitively not within the scope of the guidance that we've been working on has been NF1 and Costello syndrome, both of which have distinct genetic bases and existing robust management guidance that we'll touch on in a moment, and Legius syndrome that's sitting slightly as an orphan, but actually is not the most horrible condition to have, thankfully, so the community haven't been crying out for management guidance as far as I'm aware. Here we've got my version of the RASmap kinase pathway, which is looking horribly complicated because you always end up adding things in rather than taking them away. But just to think that actually this is complex, and the sort of turquoisey things are things within scope of what we're talking about for a Noonan syndrome spectrum, whilst acknowledging that RASopathies or germline RASmap kinase pathway disorders are kind of represented more widely and intrinsic to this network. So when we think about genotype-phenotype correlation, it's a bit of a holy grail of clinical genomic medicine. And missense substitution should be really prime targets for understanding this, shouldn't they? And one of the things that I think struck those of us who were in the Costello family joint conference yesterday is just how variable even those with G12S HRAS-related Costello syndrome can be. So it might be a fool's errand, really. But when we have a missense substitution, in principle, that should be able to confer specific gains or losses of one or more functions. And Noonan syndrome spectrum disorder associated variants, plus those for Costello syndrome, are nearly always predicted to produce a protein. So we should be in happy territory. When we think about Noonan syndrome, we've already heard about that high genetic and allelic heterogeneity, but it's relatively common overall, with PTPN11 affecting perhaps 1 in 5,000 people as the cause for a Noonan syndrome presentation. But the other half of Noonan syndrome is really genetically heterogeneous, with, of course, that still small group of patients for whom we cannot find a variant despite our best efforts at the moment. So in 2010, the original guidelines were drawn up as part of the Discern project, rooted in Manchester and led by Bronwyn Kerr, whom we're privileged to have in the audience. And at that time, most people with Noonan syndrome didn't have a molecular diagnosis, certainly in the UK and most of Europe. There weren't any particularly specific treatments that were available, and the diagnostic process was very heavily clinically orientated. And really, what we were doing was mapping out best supportive care for this group of people. We didn't really know about growth hormone. We still don't have the answers, but there is now a huge amount more evidence out there. And really, the neurobehavioral and psychological aspects were only starting to be explored. And that's something that really has changed, I think, over the last 15 years, thanks to the excellent work of many people who are in the audience this afternoon. And I just thought, thinking about how different the world was in 2010, the Nokia 5230 or 5230 was the top selling mobile phone that year. And it wouldn't run WhatsApp because WhatsApp wasn't a thing yet. So the world has changed. And it was kind of approaching 2020 that we were drawing up plans to revise the guidance, feeling it was somewhat overdue because we'd had it as an objective in 2017 at the European RASopathies meeting. But at that stage, once the pandemic was sort of slightly sorting itself out, we did manage to have defined work groups who were incorporating many of the people who've been involved with the original work in 2010, predominantly European, with some honorary Europeans and those who'd been over at the time, like Bruce. And we were able to define the scope of guidance and set people doing literature reviews and a synthesis of the evidence as Alessandro has already beautifully presented. And we had a really productive meeting, again, as he said, a few months ago in Paris, with a second round of voting that is planned for this coming month and hopefully finalisation of things by the end of 2025. Again, those of you who know me will have heard something like that before, sorry. So I think that this was just trying to think about where we're up to, but my order has got slightly strange, so I don't really need to say that. And I've already mentioned that CFC syndrome was explicitly included within this effort just because of those patients who are sitting somewhere in the middle, and also those people for whom molecular testing might not be available in their local environment. And this is something that actually we have to keep remembering, that the large proportion of the world's population don't necessarily have access to genetic testing and yet still might have a confirmed clinical diagnosis. And we also have people who have variants returned on their genetic testing that just mean we're not quite sure because the numbers in the literature are too small, or because actually they're evenly poised between those who were described as having Noonan syndrome and those who were described as having CFC, or those who were described as having Noonan syndrome, but they were 3 months old. So actually, what's the follow-up for them? Age 5, are they starting normal school, or are they still peg-fed with significant delay of their motor milestones and other developmental parameters? And Alain, who can't be here this time, but is an enormously wise and thoughtful person, has sort of put forward this argument for not labelling any such child as having Noonan or CFC until after the age of 2, when you've got some sort of feeling for what their developmental progress and other evolving features might be. And that's a really strong argument, isn't it? Until we have a family in front of us who are saying, well, what is the diagnosis, doctor? And for you to say, I don't know, is one of those kind of triple-edged swords, really, isn't it? That you are very often not in a position to just say, just wait. But actually, with better understanding of the spectrum of RAS-MAP kinase pathway disorders, of the Noonan syndrome spectrum as a positive thing, that I think can be helpful, especially for those people where we are seeing them in very early life, for example, with a variant that genuinely could turn out to look like a Noonan syndrome pattern or like a CFC syndrome pattern. So I've already shown you that, and that's just got a box round the things that we've already said are within the scope of the guidance. But within that, I think we still have to really remember that ascertainment biases are really potent in medicine in general, and this is no exception. Where we've got clinically defined conditions that we look at as a cohort, those will differ from those who are identified either gene agnostically or by broad scale genomic testing, as we have available to all of us now pretty much in this room. And I think this is something that we'll see for lots of genes across the whole genome, but RAS-MAP kinase pathway genes are a case in point, where we've got lots of people turning out to have NF1 variants, and it might be just that they're very young, that they don't meet clinical criteria yet, but equally there are plenty of older people out there as well who do not happen to have what we would think of as a recognisable NF1 phenotype and yet have a functionally important variant in that gene. And all the time we get emails from people saying, oh, I did this trio genome sequencing and it's shown up this variant in a RASmap kinase pathway gene, but I don't think they look like they have Noonan syndrome. And those of us in this room will end up having a stock reply that says, lots of them don't look like they have Noonan syndrome. I think that sort of identifiable facial phenotype and the classical pulmonary valve stenosis and short stature, yes, they're super common, but they're not common enough that absence of any of those things is enough to make us think, oh, well, that's bound to not be anything. And so NF1 is no less variable. And when we're thinking about genotype specific guidance, the NF1 guidelines were drawn up by ERN Gentouris a couple of years ago, and they actually have really shied away, I think, from including genotypic specific information, although when we're taking into account family history, clearly that actually has something. Generally speaking, despite what Anne has said this afternoon, most people with a family history of NF1 will have the same variant as one another, just in the bulk of people, won't they? And so when we're thinking about what we can do and how we risk stratify this very large group of people who we don't want to overly pathologise, but we do want to get the right amount of surveillance and care, there are several unanswered questions, even in the setting of a very well-defined clinical syndrome with very robust and long-standing diagnostic criteria and management guidance. Because how we manage those with what are reportedly mild genotypes, I think, is quite difficult. For our Manchester practice with patients with NF1 without complex complications, then actually to say, well, you should have your blood pressure checked every year and you should make sure you're aware of these particular problems, all of which are things that anybody in the general population should be getting checked out. That's not too burdensome, and so we don't have too many dilemmas there. But when we've got things like whole body MRI screening at our disposal, but not for all of the patients who might want it, how do we actually define that? And so what we do in Manchester is thinking about the generic sort of sets of information that we have about an individual person. And if they have a whole gene deletion or one of the high-risk missense genotypes, such as the 844 to 848 missense substitutions, we do consider or offer a whole body MRI scan at roundabout transition age, or ideally in the early 20s when people have finished growing, because if at that stage they have shown not to have a significant internal burden of disease, we can be happy that unless there are other identified risk factors, their risk of malignant peripheral nerve sheath tumour should be under the sort of 10% all-comers risk in NF1. And again, those with whole gene deletion, we will often be seeing on an ongoing basis within our service, either yearly or every 2 years. And so for them, we don't feel we're losing them, and that's quite straightforward. When we're thinking about people whom we might otherwise not be following up, things like breast cancer risk assessment are really important to make sure we've updated the pedigree, not just thinking about NF1, but thinking about any other tumours that might have happened in the family, any other evidence of something that might nudge that, particularly woman in front of us, into, for example, a high-risk screening group rather than the moderate risk, which is standard for people with NF1. From the point of view of Costello syndrome, I've already said the sort of codon 12 cohort represent a large majority of those with Costello syndrome, and so that's kind of really easy, that you can have the guidance, make sure that families and local caregivers are able to access it. And actually my impression from talking to families at this meeting is that they are accessing the recommendations really pretty robustly across the board. Of those that I've spoken to, I don't know what other people would speak to. And so for classic Costello syndrome, that's relatively straightforward within the context of this highly complex condition. But when we have milder variants, that's really tricky to know how much should we actually emphasize the importance of screening for people where actually there might be quite a number of people with variants of a particular codon who haven't been identified to have rhabdomyosarcoma, for example. And so at the moment, I did check with Karen yesterday that she would still say to people, you know, go along with the guidance, but know that actually you're at slightly lower risk of troubles. So have stuff, but don't worry as much about it. And again, as we accumulate evidence over what will probably be decades for the scale of patients that we have available to us to understand, we might be able to refine those in years to come. If we think about briefly how we might think about particular clinical phenotypes, we know that hypertrophic cardiomyopathy risk is much higher in some genotypes than others, and that's something that Katie and others have talked about today. And that was something that I think when we started out with the refresher of the Noonan syndrome guidelines, we thought, well, that's bound to be something that we need to take into account. And clearly it needs to be in the narrative account of how we understand these conditions. But actually, when it boils down to it, our advice, simpler is better. And if actually the baseline advice is the same for everybody, we perhaps don't need to have headline genotype specific information about all of the manifestations, which is a relief, I have to say. So that was my reminder to myself not to talk too much, which has failed as always. And just a couple of other specific genotypes that we were thinking about in terms of that higher risk of growth hormone deficiency that we see with SHOC2. But actually, we're going to be thinking about growth parameter monitoring being important for all children with Noonan syndrome. So perhaps it's important for the individual family to know that there's a higher risk, but it doesn't actually change what our baseline advice is likely to be. And similarly for CBL-associated Noonan and the JMML risk, actually, we want to have good awareness of things, but even recommending quarterly blood counts is not something that necessarily is acceptable to families and certainly the children themselves. And so good awareness and early investigation in the event of concern is more important. And exactly the same story, we think, probably for lymphatic problems, although other people will talk to that in more detail. So the lessons we've learnt are thinking that our evidence base remains predominantly at the level of expert opinion. And there's a huge amount of culture that actually varies from place to place, particularly about follow-up and who sees people, how long they keep hold of them as they age out of the paediatric population. But it's really a primal need to avoid unnecessary anxiety and for the burden of the recommended guidance that many families we know will cling to and follow through no matter what. It's really important that that's minimally burdensome and we don't end up pathologizing people who actually ought to be getting on with stuff. So I think that was all I was going to say. And just an enormous thank you to absolutely everybody who's been involved. There are some fantastic people who've given lots and lots of time and lots of energy to this project. And I want to thank them all.
Thank you, Emma. And I'm looking forward to seeing the published recommendations coming out in the near future as you advertised. Are there any specific questions for Emma's overview? I think this seemed a whole lot less controversial than the other talks. Please.
Thank you for that great talk. So one question I had is, and it seems like there's a lot of work to even sort of understand the contribution of individual alleles to particular phenotypes, but how about polygenic contribution? Is there work is there work being done to at least sort of collect the data or sort of try to have something that in the future could be accessed? Because I feel like that's naturally some direction that this may go into.
I mean, I think it's better advanced for something like breast cancer risk, where there are polygenic risk scores that can be applied, and quite how they sit within the context of an NF1 specific risk, I don't know, and we need to mine Gareth Evans's brain before he finally checks out to France forever. But on the whole, I think we're a very long way away from any of that, and probably actually it's going to be more about family history of things. So for example, short stature is a really good example, isn't it, where if you have tall parents and actually the child is relatively tall for Noonan syndrome as well, you kind of have got a good explanation for that, haven't you? And so there's something about taking into account all of the information you've got available that I think is helpful, and it's what we sort of do day in, day out, thankfully. But I think in terms of polygenic risk scores, are you talking about RASMAP kinase pathway specific alleles or across the whole genome? Because I know nothing about either of those.
Right. I guess I was thinking more broadly, just because some of these, as you said, some of these specific alleles may be impacted by genes outside of the RAS-MAP kinase pathway, which
Absolutely.
would be relevant. Yeah.
Hello. I guess one of the elephants in the room for all of us is that we all know people who have been diagnosed with Noonan syndrome at the same time that their child has, whose Noonan syndrome is manifestly mild while their child's is serious. And given the title of the talk being that genotypes matter, I just wondered what the future was of trying to predict based on more than the genotype, and whether there was epigenetic involvement in terms of looking at expression or severity, and whether that was a line that needed to be pursued.
I think there's a load of stuff we don't know and we're not going to know anytime soon is probably the case. It's not rare to have a second functionally important allele, and thankfully with a panel-based approach or a whole exome, whole genome-based approach, we will pick out some of those. So the people who've got an inherited mild SOS1 variant that means that dad's got curly hair and slightly funny eyebrows, and then the child has got a PTPN11 variant as well, it's not an uncommon scenario. And that at least helps us to understand why they might be more severely affected, perhaps.
Hey, Emma, thanks. I just want to comment about the PRS and those kind of like looking at other common genetic variation. There is one example in rare genetic condition in 22q deletion syndrome that they were able to use PRS score to increase the prediction of schizophrenia in this case. I'm kind of like saying that for the community, that in order to do that, we have to all of us work together and collect enough samples so we can actually test it. Those proposals usually fall on not enough cohort. So yeah.
And so is that on the basis of GWAS data?
Yes.
Thank you, Emma. We'll now move on to the last talk in the session.